Guys chattering away up there. Happy bunch, which is great. All right, we're prioritizing what I think is going to be most important. And this aldosterone / adrenal is the big ticket item. So we're going to talk mostly about aldosterone. And you can't do aldosterone without talking about adrenal function. And here's the syllabus, my version of a nicely organized syllabus. So we'll do just the action. And this is not headline news. You guys know this stuff for sure, but it gets complex as we go. First and foremost, what is the main purpose of aldosterone? And I want to emphasize this idea of maintaining blood volume, because when we talk about ADH later this morning, and that's really the fine tuning of serum osms for sure, but also and it tells us, we want to absorb that extra free water. But at the end of the day, aldosterone is how we maintain our blood volume. How does aldosterone do its thing? It drives the sodium potassium ATPase pump, number one. Number two, it increases the density of these electrochemical sodium channels. And in the process, we're wasting potassium. And all that's important because, first of all, it's about sodium retention and chloride to follow, water to follow, restoring blood volume, and we're losing K in the process. Those are the hallmarks of aldosterone and ultimately aldosterone hyperfunction or hypofunction that we'll get to. It has this other action, which is really important because it becomes the language of aldosterone function for whatever cause. It stimulates this hydrogen ATPase pump in the intercalated cells. So it causes wasting of hydrogen ions with consequent absorption of bicarb. So one of the hallmarks, not just sodium absorption, but the other key thing is this metabolic alkalosis. So that's a big ticket item. Metabolic alkalosis, you have to recognize, is the language of aldosterone. We'll get to hyperaldosteronism, hypoaldosteronism. So, but too much aldosterone, metabolic alkalosis, adrenal failure, metabolic acidosis. So what I want to emphasize here is really the language. So first of all, too much sodium absorption does not equal hypernatremia because of, again, aldosterone escape that we'll get into and counterregulatory mechanism. Too much sodium absorption equals hypertension. And on the boards, when they want you to focus on hypertension, they'll give you numbers to focus on. Systolics 180, diastolics 110. So they go hog wild. So too much aldosterone, hypertension, hypokalemia, metabolic alkalosis, that is the language of hyperaldosteronism. And I am doing a side-by-side. I'm not doing, hey, here's hyperfunction, and then a separate lecture on adrenal insufficiency. They need side-by-side, number one. And number two, it's much easier on the compare and contrast. So excess, I said hypertension, not hypernatremia. But the flip doesn't apply. So aldosterone deficiency, as in adrenal insufficiency by and large, right? We're wiping out the adrenal gland to lose out on aldosterone. Too little sodium absorption, certainly hypotension, but here now we're going to have hyponatremia. Because we don't have aldosterone, we're not absorbing sodium, and we're volume deplete, ADH is up. So the flip side, when you don't have aldosterone, you will have hyponatremia. But when you have too much aldosterone, it's hypertension. The flip side, again, aldosterone deficiency, hyperkalemia, metabolic acidosis. Of the signs or symptoms, this has to be a knee jerk. You see low sodium and hyperkalemia, you have to be thinking about adrenal hypofunction. In terms of too much sodium, we have hypertension. And remember, we have ADH, and we'll get to ADH later this morning, in response to osmoreceptors. So if you're absorbing too much sodium, ADH is going to kick in to normalize the serum osms, okay? Again, we'll get to aldosterone escape, but hypernatremia is not part of the diagnosis of hyperaldosteronism, but hyponatremia, because of now baroreceptors and angiotensin stimulate ADH, so you have hyponatremia. You just have to be suspicious of those findings, hyponatremia, hyperkalemia. So that is the language of both excess mineralocorticoids. Although we're talking about aldosterone, I'm kind of integrating other things. Cortisol will do the same thing. Very high cortisol level will give you the same footprint of hypertension, hypokalemia, metabolic alkalosis as aldosterone. And I'm also emphasizing adrenal failure, because how do you get to too little aldosterone? Either you don't synthesize it or you wipe out the adrenal gland. So primary adrenal failure. Secondary adrenal failure, as in hypopituitarism, where you're not secreting ACTH, does not affect aldosterone secretion. The adrenal gland has to kind of crap the bed to get too little aldosterone. So they do make a big point, and we'll get into this with the biosynthesis of aldosterone. is aldosterone synthesis is not dependent on ACTH. It's dependent on renin-angiotensin stimulating aldosterone secretion. ACTH is important for cortisol. It's important for the androgens in the adrenal gland, but aldosterone secretion is not dependent on ACTH. All right, which brings us to biosynthesis.